Okay, let's dive straight into a topic that often sits right at that intersection of personal appearance and, well, underlying health.
Yeah.
We're talking about excessive hair growth, particularly in women, that follows a pattern you might not expect, a pattern that can actually be a really important signal something deeper is going on inside the body.
Exactly. It's easy sometimes to dismiss unwanted hair growth as, purely cosmetic, but when it's excessive and in those specific areas, it's a key clinical sign. It really is.
Right.
So today we're doing a deep dive into the medical condition known as hirsutism.
And our mission with this dive,
Yeah.
using some detailed revision content that listeners have shared, is really to cut through the noise. We want to give you, the listener, a really high-yield breakdown of hirsutism, what it is, why it happens, how we figure out the cause, and how it's managed.
Yeah, think of it like a focused revision session.
Exactly. Just targeted, making those crucial points stick.
It's about getting to that core understanding quickly. So let's start with that fundamental question. What exactly is hirsutism? Because, not all excess hair growth is hirsutism.
That's a critical distinction, isn't it? What makes hirsutism, well, unique?
Okay, the absolute key thing with hirsutism is the pattern and the type of hair. And crucially, it's linked to hormones.
Right.
Hirsutism is defined as excessive growth of, well, coarse, pigmented hair in women, but specifically it follows a male pattern.
Male pattern.
So this means hair showing up or increasing significantly in places like the upper lip, the chin, jawline, chest, upper back, lower abdomen, inner thighs. Areas where women typically have very fine hair or none at all.
Okay.
It's not just more of that fine, light vellus hair. It's the thick, dark terminal hair you see.
Okay, so location and the quality of the hair, those are the big markers. And you mentioned hormones.
Absolute critical. Hirsutism is directly linked to either increased levels of androgen hormones like testosterone. We often think of them as male hormones, but women have them too, of course.
Yeah. So it's either too much androgen, or sometimes it's just an increased sensitivity of the hair follicles in those specific areas to normal levels of these androgens.
Ah, okay, so the follicles are sort of overreacting.
Kind of, yeah. Or the signal's too strong. So male pattern, coarse hair, driven by androgens or that follicle sensitivity, that's hirsutism.
Got it. What about the other term you sometimes hear batted around, hypertrichosis? How's that different?
Yeah, good point. Hypertrichosis is fundamentally different. It's more of a generalized excessive hair growth. It could be all over the body or maybe in patches, but crucially, it is not caused by increased androgens, and it doesn't follow that specific male pattern.
So no hormone link there.
Not in the same way, no. It's not androgen-dependent. And it could be vellus hair or terminal hair, but the trigger and the distribution are the key things that set it apart from hirsutism.
That makes the definition really clear then. Hirsutism,
Right.
specific androgen-driven, male pattern, coarse hair in women. Hypertrichosis. Just kind of generalize extra hair. Not hormone-driven in that way.
And understanding this difference is crucial, right? Because hirsutism points you towards investigating those hormonal causes.
Precisely. And while sometimes, no clear cause is found, that's what we call idiopathic hirsutism most of the time, hirsutism flags an underlying issue. And polycystic ovary syndrome, PCOS, is the runaway most frequent cause by far.
Right.
But it's vital to remember it can also signal more serious underlying issues, like problems involving excess androgens coming from the ovaries or the adrenal glands.
Okay, that leads us perfectly into the why,
Yeah.
the etiology, the causes. If the main driver is this increased androgen activity, what are the specific conditions or factors that actually cause that?
Right. So you're looking for anything that either produces too many androgens or makes the body more sensitive to them. And like we just said, PCOS is the most common cause. It accounts for the vast majority of cases.
PCOS is just incredibly common anyway, so that makes sense.
It really does. Then you've got idiopathic hirsutism. That's basically hirsutism where all the investigations don't find another underlying cause. It's often thought to be just that increased follicle sensitivity we mentioned. It can run in families too.
So they have the hair growth, but their hormone levels might actually look normal on tests.
Potentially, yes. Or maybe only slightly elevated. It varies. Beyond those two big ones, medications can definitely induce hirsutism. You always need to think about that.
Like what?
Things like glucocorticoids, steroids, danazol, and certain types of progestogens that are found in some older contraceptive pills, the more androgenic ones.
I was going to check the drug history then.
definitely.
What about where androgens are actually produced in the body?
Exactly. The main sites of androgen production in women are the ovaries and the adrenal glands. So naturally, conditions affecting these are key causes to consider. So ovarian causes primarily include PCOS, obviously. Also, the normal hormonal shifts during menopause can sometimes increase relative androgen effects. And then, much less commonly, you can have androgen-producing tumors of the ovary.
And the adrenals.
Adrenal causes, again, can include adrenal tumors, which are rare but important, congenital adrenal hyperplasia, or CAH, particularly the non-classical or late-onset form, and Cushing's syndrome, where you have excess cortisol, which can sometimes mess with androgens too.
Wow, that's quite a spectrum, isn't it? From really common things like PCOS right through to rare tumors.
It absolutely is. And the speed of onset can be a really useful clue. If hirsutism develops very rapidly or it's very severe, that should definitely make you think more about those concerning causes like tumors.
Okay.
There are also other medical conditions linked less commonly, things like severe insulin resistance, anorexia nervosa, certain pituitary conditions like prolactinoma or acromegaly, hypothyroidism, and even porphyria has been linked.
Gosh, it sounds like if you see significant hirsutism, it really triggers quite a broad mental checklist of potential underlying conditions you need to work through.
That's exactly the approach.
What about in younger people, like children or adolescents?
Right. So hirsutism starting around puberty can sometimes just be familial, running in the family. But if it appears before puberty, that's a much stronger indicator to look seriously for an underlying disease.
Okay.
Classic CAH, for instance, can start very early, whereas the late onset form of CAH typically presents after puberty and can look a lot like PCOS. And then there are some very rare chromosomal conditions like 46XY disorders of sex development that might present with hirsutism at puberty.
Okay, so the timing, the age of onset is another key piece of the puzzle. Are there specific things that just increase someone's risk of developing hirsutism in the first place? Risk factors.
Yes, definitely. Key risk factors mentioned include having a family history of hirsutism itself or other related androgen conditions like PCOS. Obesity is also a significant factor.
We keep hearing about obesity.
Yeah, it's often linked because it can contribute to insulin resistance, which itself is listed as a risk factor. And, well, naturally, having one of those predisposing medical conditions like PCOS or an adrenal disorder inherently increases your risk.
Right. So family history, weight, insulin issues, and those known conditions. Pretty clear risk factors there. Now let's get into the how, a bit more the pathophysiology. How does this hormonal imbalance, this androgen excess or sensitivity, actually cause that thick, dark hair to grow in those specific male pattern areas?
Okay, think of it like this. Hair follicles are like tiny factories, right? And androgens act as a specific kind of growth signal for certain types of hair. Now, for most women, the follicles in areas like the face, chest, and back are less sensitive to this androgen signal. So they produce very fine vellus hair or maybe no hair at all. In men, these same follicles are highly sensitive to androgens, and that's why they produce the coarser terminal hair in those areas.
So these are the androgen-sensitive areas we talked about.
Exactly. So in hirsutism, what's happening is either the body is producing way too much of that androgen growth signal, the signal itself is just too strong,
Okay.
or the follicles in those specific male pattern areas have become more sensitive. They're picking up even normal or maybe just slightly elevated androgen levels much more strongly than they should.
Like the volume knob is turned up too high in the receiver.
That's a great analogy, yeah. The signal's received louder, basically, and so that follicle switches from making fine vellus hair to making coarse, pigmented terminal hair.
So it's either a stronger signal or a receiver that's turned up too high. That really helps visualize it.
That's pretty much the core mechanism. And conditions like PCOS, adrenal problems, or certain drugs, they disrupt this delicate balance, leading to that excessive terminal hair growth in those male pattern areas.
Got it. Okay. So we know what it is, why it happens, how it happens. Let's just quickly revisit those differential diagnoses. What else could it be that you really need to rule out or distinguish it from?
Right. So the first and most important distinction, as we've said, is separating hirsutism from hypertrichosis. Is this androgen-driven male pattern growth, or is it that generalized non-androgen hair growth? You have to establish that first. Once you're pretty sure it is hirsutism, then the diagnostic challenge really becomes figuring out the specific underlying cause.
Right, like is it PCOS or is it maybe CAH or Cushing's or something rarer?
Precisely. And crucial here is actively ruling out those more serious, often rapidly developing causes, like the androgen-secreting tumors of the ovary or adrenal gland. You need to distinguish it from conditions like CAH or Cushing syndrome as well.
Okay.
And remember, idiopathic hirsutism, where you don't find a cause that's a diagnosis of exclusion. You only arrive at that after you've done the investigations and ruled out these other specific causes.
Right.
And of course, you're also just distinguishing it from normal individual variations in vellus hair patterns, which aren't actually hirsutism at all.
That makes sense. You have to actively look for and exclude the potentially serious stuff before settling on idiopathic or common causes like PCOS. Let's talk about who this affects the epidemiology. How common is it, actually?
Well, in the UK, studies suggest hirsutism affects somewhere between 5% and maybe 15% of reproductive aged women. So it's definitely not a rare condition.
5 to 15%, that's quite a range, but significant.
It is. And as we know, PCOS is the most frequent underlying cause, and PCOS itself affects about 5% to 10% of women in that same age group.
Wow. So does that mean most women with PCOS likely have some degree of hirsutism?
Many do, yes. Maybe not always moderate to severe, but it's certainly a very common feature of the syndrome. It's one of the key diagnostic criteria, in fact.
Okay.
There are also some ethnic variations noted. It's reported as being less common in women of, say, East Asian descent, for example. And importantly, cultural factors significantly influence how hirsutism is perceived and the level of distress it might cause someone.
That's a really good point. How do we actually measure how severe it is clinically? Is there a standard way?
Yes. The standard tool used is the Ferriman-Galway score. It's a scoring system where you assess hair growth on 9 specific body areas, like the upper lip, chin, chest, back, abdomen, etc.
Right.
Each area gets a score from 0, meaning no terminal hair, up to 4, meaning extensive terminal hair growth. You add up the scores from all 9 areas.
And what score is considered significant?
Generally, a total score over 15 is taken to indicate moderate to severe hirsutism. Sometimes this score needs a bit of adjustment based on ethnicity, as baseline hair patterns can vary. And interestingly, a higher score is often associated with obesity as well.
There's obesity popping up, again a risk factor associated with severity. Okay, so beyond the hair itself, what other clinical features might someone with hirsutism present with, especially if there's significant androgen excess going on?
Right. This is where it becomes really clear that hirsutism often isn't just about the hair. If the underlying cause involves significant androgen excess, you'll often see other signs of virilism. These are features related to having higher levels of male hormones.
What kind of features are we talking about?
Well, the sources list things like acne, that's very common. Also, male pattern hair loss, so alopecia, often with recession at the temples. A tendency towards male pattern obesity, carrying more weight around the abdomen.
Okay.
More pronounced signs indicating higher androgen levels can include clitoromegaly, that's an enlargement of the clitoris, deepening of the voice, increased libido, and increased muscle bulk, particularly noticeable around the shoulder girdle. You might also see a loss of typical female body contours or changes in breast tissue.
Wow, that sounds like a whole constellation of potentially quite significant changes.
It really highlights the systemic effects that high androgens can have. And alongside these physical signs, you'll very frequently see menstrual dysfunction, anything from irregular periods, oligomenorrhea, right through to complete absence of periods, amenorrhea, and consequently infertility is common too.
Are there other sort of metabolic or systemic problems linked to these high androgen states?
Yes. Absolutely, and this is really high yield for understanding the broader health implications. High androgen levels are associated with an increased risk of cardiovascular disease long term. Also, dyslipidemia, unhealthy cholesterol and triglyceride levels. Glucose intolerance or overt insulin resistance, potentially leading to type 2 diabetes, and hypertension, high blood pressure.
So major metabolic red flags.
Definitely. And another key sign to look for on examination is acanthosis nigricans. That's the dark velvety thickening of the skin you often see in the neck folds, armpits, or under the breasts. It's a strong marker for significant insulin resistance. And, though rare, you always have to consider, could there be a pelvic or abdominal mass if a tumor is the underlying cause? Needs careful examination.
So the hair is really just the visible tip of an iceberg that could potentially include serious metabolic issues, reproductive problems, and even, rarely, tumors.
You mentioned the psychological impact earlier. Can we touch on that again? It sounds crucial.
Absolutely. And I think it's arguably the most significant complication of the hirsutism itself. The excessive hair growth, especially facial hirsutism, can be incredibly distressing for women.
I can only imagine.
It profoundly impacts self-esteem. It can lead to significant anxiety, depression. It causes real emotional distress and social embarrassment, severely affecting quality of life.
Yeah.
The sources specifically note a strong link found between the presence and severity of hirsutism and symptoms of anxiety and depression.
So this isn't just vanity, it's a major mental well-being issue.
Exactly. It's not just cosmetic. It has major implications for mental health and daily functioning. That's such an important point to emphasize. Okay, given this complexity, how do we actually go about figuring out the underlying cause? What are the investigations we should be thinking about?
It's a systematic process, really. You start with a thorough medical history and a targeted physical exam, then you move on to laboratory tests, and sometimes imaging might be needed.
Okay, what are the key things you're asking about in the history?
Key questions include, when exactly did the hair growth start? Crucially, was the onset sudden or gradual? What's their menstrual cycle like, regular, irregular, absent?
Yeah.
What medications are they taking, including any supplements? Is there any family history of hirsutism, PCOS, infertility, or diabetes?
Right.
And importantly, asking specifically about any other symptoms like voice changes, hair loss from the scalp, rapid weight changes, muscle bulk changes, things that might suggest significant virilism or maybe point towards Cushing's.
And then the physical exam. What are you looking for there?
You're obviously assessing the degree and pattern of the hirsutism, ideally using the Ferriman-Galway score to quantify it. You look carefully for those other signs of hyperandrogenism. We discussed acne, alopecia, clitoromegaly, signs of Cushing's too, like central obesity, striae, bruising. You must check blood pressure and calculate the BMI. And perform an abdominal and pelvic examination to feel for any possible mass.
Okay. When would you definitely trigger investigations or think about referring someone on?
You should definitely investigate or refer if you clinically suspect androgen excess based on those signs and symptoms, especially if the hirsutism is rapidly getting worse or if it's very severe. Also, if there's associated infertility or significant menstrual irregularity like oligomenorrhea or amenorrhea, those are clear triggers.
Makes sense. What are the key initial tests you'd order?
The key initial blood tests are usually total testosterone. Sometimes free testosterone or the free androgen index gives a better picture, but total testosterone is the start. And definitely 17-hydroxyprogesterone, that's the key screening test for the common forms of congenital adrenal hyperplasia, CAH. Looking at the FSH and LH levels can also be helpful. An elevated LH to FSH ratio, say greater than 2 or 3 to 1, is often seen in PCOS, though it's not universally present.
Right. And if you're suspicious of other things, based on the clinical picture.
Yeah, if there are features suggesting Cushing syndrome, you'd need to do specific tests for that, like a 24-hour urine-free cortisol or a dexamethasone suppression test. Always rule out pregnancy in women of reproductive age before starting certain treatments or investigations. And it's often sensible to check prolactin levels and thyroid function tests, TFTs, as abnormalities there can sometimes cause menstrual irregularities that might overlap.
What about imaging? When does that come in?
Imaging isn't usually first line for simple hirsutism, but it's used if you suspect a specific ovarian or adrenal cause based on the clinical picture or very high hormone levels. A transvaginal ultrasound is the best way to look at the ovaries, checking for polycystic morphology or any ovarian tumors. And adrenal gland imaging, usually with a CT or MRI scan, would be needed if you suspect an adrenal tumor or hyperplasia.
Okay, let's do a quick mini scenario. A patient presents with moderately severe hirsutism, irregular periods, and acne. You take a history, do an exam. Initial bloods show moderately elevated total testosterone, maybe a raised LH-FSH ratio, and a normal 17-OHP. What's likely going on and what's the next step? Mini vignette example.
Right. Well, that picture hirsutism, irregular periods, maybe some acne, moderately raised testosterone, maybe that LH-FSH ratio flipped, and a normal 17-OHP ruling out common CAH that is highly suggestive of polycystic ovary syndrome, PCOS.
Okay.
The next step would often be a transvaginal ultrasound to look for polycystic morphology of the ovaries, which would further support the diagnosis according to the Rotterdam criteria. Management would then focus on addressing the PCOS symptoms, including the hirsutism.
That helps connect the dots. When is referral definitely warranted, either for diagnosis or management?
You should definitely refer if your initial investigations point towards specific rarer conditions like acromegaly or Cushing syndrome, as they need specialist management. If you suspect an androgen-secreting tumor, particularly if testosterone levels are very high or the onset was very rapid, that needs an urgent referral to endocrinology or gynecology.
It's urgent, okay.
And also, if the hirsutism isn't adequately controlled with the initial treatments available in primary care, referral for consideration of second-line or specialist therapies is appropriate.
Okay, so we figured out what might be causing it, or we've ruled out the serious stuff. How do we actually manage hirsutism? What's the management approach look like?
Management is usually multifaceted. It involves tackling the hair growth itself, but also, crucially, treating the underlying cause if one is identified.
Right.
You'd normally start with non-pharmacological approaches. Lifestyle modification is key, especially if the woman is overweight or obese. Weight loss, even moderate amounts, can be very beneficial, particularly in PCOS, where it can improve insulin sensitivity, restore ovulation, and lower androgen levels.
So lifestyle first. And what about dealing with the hair directly, the cosmetic side?
Yeah, there are various cosmetic techniques. Simple things like shaving or bleaching are accessible. Waxing or plucking pulls the hair from the root, so the effect lasts a bit longer. Then there's electrolysis and laser hair removal, which aim for longer-term reduction by damaging the hair follicle itself.
Are these usually available on the NHS?
Generally, no. The sources point out that cosmetic treatments like waxing, bleaching, electrolysis, and laser hair removal, while potentially effective, especially short-term for laser, are not usually funded by the NHS for hirsutism. Shaving is obviously self-managed.
Okay, so cosmetic options are there, but often self-funded. What about medical treatments, pharmacotherapy?
Medical therapy focuses on reducing those androgen effects. Combined oral contraceptive pills, COCPs are often considered first-line treatment, especially for women who also want contraception,
Right.
particularly pills that have anti-androgenic properties. Good examples given are ciclosporin, which is specifically licensed for severe hirsutism and acne, or pills containing ethinylestradiol combined with drospirenone, like Yasmin, which also has anti-androgenic activity.
How do they work?
They work in a couple of ways. They suppress LH release from the pituitary, which reduces ovarian androgen production. They also increase the production of sex hormone-binding globulin, SHBG, in the liver, which binds up free testosterone, making less of it available to act on the hair follicles.
Okay, so COCPs are a common starting point then. Are there any topical options?
Yes, there's a topical cream called eflornithine. It's licensed specifically for slowing the growth of facial hair in women. It works by inhibiting an enzyme called ornithine decarboxylase, which is important for hair growth. It doesn't remove hair, but slows regrowth. It's reversible, so needs continuous use.
Facial hair only, though. What about the anti-androgens you mentioned earlier, like spironolactone?
Yes, anti-androgen drugs can be used, often as a second-line option, perhaps added to a COCP if the response isn't enough after, say, 6 months. Spironolactone is commonly used off-label for this in the UK. Others mentioned include flutamide and finasteride, though these might have more side effects or specific concerns.
How do they work?
They work by directly blocking the androgen receptor at the hair follicle or by inhibiting the enzyme 5-alpha reductase, which converts testosterone to the more potent dihydrotestosterone, DHT.
Right. But you mentioned a really important warning about pregnancy.
Absolutely crucial. Anti-androgens must not be used during pregnancy because they can cause feminization of a male fetus, serious birth defects. So any woman of childbearing potential using these drugs must use highly effective contraception. It's non-negotiable.
Very important point. Are there any options reserved for very severe or resistant cases?
Yes, for very severe hirsutism that hasn't responded to other treatments, gonadotrophin-releasing hormone, GnRH agonists, can be considered, usually under specialist supervision. They effectively shut down ovarian hormone production, including androgens, creating a sort of medical menopause.
It sounds quite drastic. Side effects.
Yes, they come with significant side effects like hot flushes, vaginal dryness, and importantly, potential bone demineralization with long-term use, so they often require add-back therapy with low-dose estrogen and progestogen. They're really reserved for specific, difficult situations.
And metformin, where does that fit in?
Metformin is primarily used in PCOS to improve insulin sensitivity and help regulate menstrual cycles. While doing that can indirectly lower androgen levels over time, there's limited direct evidence that metformin alone is effective specifically for managing hirsutism. It targets the underlying metabolic issue in PCOS rather than the hair directly.
Okay, so it's part of the PCOS management puzzle, but not a primary hirsutism treatment itself. So it sounds like a stepped approach generally. Lifestyle, maybe COCP, add topical eflornithine for face, consider anti-androgens with contraception, and then specialist options like GnRH agonists for severe cases.
That's a pretty good summary of the typical pathway, yeah. Always addressing the underlying cause where possible, too.
And the referral indications for management seem similar to those for investigation, basically. Suspected serious underlying cause or failure of primary care treatment.
Exactly. Features suggesting Cushing's or a tumor need referral. Significantly abnormal hormone levels often need specialist interpretation and management. And if hirsutism remains uncontrolled and distressing, despite trying appropriate primary care options like COCPs plus anti-androgens for a reasonable period, then referral to endocrinology or dermatology is warranted. And again, any suspicion of an androgen-secreting tumor requires that urgent referral.
Right. Okay, once management is started, what's the prognosis generally like? Can the hair growth be completely reversed?
The prognosis really depends heavily on the underlying cause and how effectively the chosen treatment addresses it. With appropriate management, the excessive hair growth can typically be controlled and significantly reduced, which is often the main goal, and leads to a big improvement in quality of life.
But maybe not completely gone forever.
Often not completely eradicated, no. It frequently requires long-term, ongoing management, especially for chronic conditions like PCOS, which don't just go away. Regular monitoring is really key to track the response to treatment, adjust therapy as needed, and watch for any recurrence or potential side effects or complications of treatment. It's usually more about achieving good control than a permanent cure.
So it's often a journey of ongoing management rather than a quick fix. Finally, let's talk about potential complications. Are there serious risks from hirsutism itself?
Hirsutism itself, the hair growth, isn't typically associated with serious physical complications directly. Maybe some skin irritation or folliculitis from hair removal methods, but nothing major inherently from the hair. The major complication, as we've really emphasized, is the profound psychological impact. The decreased self-esteem, the anxiety, the depression, the emotional distress, the social embarrassment, these can be genuinely debilitating and are probably the most significant burden of the condition itself for many women.
It sounds like treating that psychological aspect, providing support, maybe psychological therapy, is just as important as the physical treatments for the hair.
Absolutely. It needs to be addressed directly. And while the hirsutism itself might not cause major physical harm, it's absolutely vital to remember that the underlying conditions causing the hirsutism often do carry significant risks of physical complications if they're left untreated.
Right. Like the risks associated with PCOS.
Exactly. Untreated or poorly managed PCOS carries increased long-term risks of type 2 diabetes, cardiovascular disease, dyslipidemia, hypertension, and even endometrial cancer. Similarly, conditions like Cushing syndrome or untreated tumors have their own potentially severe health consequences. So while managing the hair itself is crucial for the patient's quality of life and mental well-being, diagnosing and effectively treating the underlying cause is absolutely vital for their overall long-term physical health.
That really puts everything into perspective, doesn't it? Hirsutism is the visible symptom, the thing that often brings the patient in. But it's frequently a signal pointing towards these deeper metabolic or endocrine issues that require really careful evaluation and management, not just for cosmetic reasons, but for the person's overall health.
Precisely. It's often a diagnostic puzzle that needs to be solved comprehensively, looking beyond just the surface symptom.
This has been a fantastic high-yield run-through of hirsutism. We've covered the key aspects from definition right through to management and complications, just the kind of targeted review that's super helpful for revision. It's really quite fascinating how a seemingly straightforward symptom like excess hair can unlock such a wide range of potential underlying diagnoses.
It really underscores the importance, doesn't it, of taking every clinical sign seriously and investigating thoroughly when needed. Never dismiss things too quickly.
Absolutely. Well, for more free MSRA revision resources, do visit freemsra.com, and for the full premium revision toolkit, you can head over to pastthemsra.com.